Good morning, everyone. It's my pleasure and honor to be included in the 23rd International Thalassemia Association meeting. And of course, I would like to thank Professor Dr. Amel for giving me the chance year after year to be included in such a prestigious meeting. And we should remember, this meeting is celebrating what's called World Thalassemia Day. And because we are celebrating such day, we should remember the right of these patients. And one of the very important rights is giving them good quality blood. Blood is the cornerstone in this disease. However, the advances we get, still the blood is a cornerstone. And because of that, this is the title of my talk. Title of my talk is Transfusion-Associated Immunomodulation, Facts and Fear, and how to give good quality blood of these patients. This is my disclaimer, and these are the outlines I will get. In thalassemia patient, we always go for what's called autologous blood transfusion. Autologous blood transfusion. What does it mean this? It means a lot. It means that I take blood from a donor to a recipient. It means the survival of these patients improved a lot by giving them allogenic blood transfusion. And over years, look how blood transfusion improved the survival, and we received this slides from the TIF yesterday. So allogenic blood transfusion, there is a solid fact. It's a biological product that saves life, especially among thalassemic patients. However, it's important and saves life. However, this allogenic blood transfusion, it's donor give blood to a recipient. And these two people is completely different from each other in all things. In their red blood cell antigens, in their platelet antigen, in their plasma, in their white BCs. This is beside the bioactive lipid present in the blood bag due to the processing of the blood bag and the storage and the processing damage that happened from this stored blood in the blood bag. All these things raise our voice and ask, is it still safe? Giving blood, is it still safe? The answer, unfortunately, will raise a fear. A fear. It saves life, definitely yes, but it carries many fears. Some of these fears are known, like infection consequences, plasma-related allergic reaction, white disease like febrile reaction, and definitely red blood cell consequences like hemolytic reaction. All of us know these fears, and there is a great improvement in managing such fears. However, there is still another fear. We should be aware of it. Let us go together. What's this fear? This fear, this biological product is full of many antigenic particles from a donor. And these antigenic particles will go to the recipient body. And mandatory, it will initiate what's called immune inflammatory abrasions inside the recipient body. And this is called the TRIM, or the transfusion-related immunomodulation, the topic of us today. So this is one of the consequences of the blood transfusion, which should be clearly managed to be sure we are giving safe blood. Let us go a bit, take a glimpse on this topic. It's still risky because of this TRIM. What's TRIM? TRIM, it is the changes in the immune system and the immune response of the recipient due to the transfusion of these antigenic material. What is its mechanism? Let us understand its mechanism to know how to manage this problem. The mechanisms are plenty. For the sake of the time, I will select some of these mechanisms. One of these mechanisms, the allogenic blood bag, will carry white BCs. And this white BCs, when it's entered into the recipient body, it will act as a non-professional antigen-presenting cells. And this non-professional antigen-presenting cells that enter from the donor bag to the recipient body will stimulate the recipient T cell, but it will stimulate it in a wrong way, in undesirable way, because this stimulation will lead to change of the immune responses to the T helper 2 side, with all the bad cytokines of this response. Besides, in this T cell may be transformed into what's called anergic cell, means the immune system of the recipient will be unable to mount immune response when he faced or it faced a foreign antigen. And some of this bad maturation of the recipient T cell, it will be matured into suppressor T cell. And these changes will be aggravated by continuous exposure to allogenic blood. By continuous exposure of this allogenic blood, more and more changes in this T cell stimulation will happen, and this of course will lead to immunosuppressed person. So any person received allogenic blood transfusion, his immune system is a bit immunosuppressed with the T helper 2 responses, with all the cytokines of the T helper cells. And beside being immunosuppressed, sometimes the anergic T cell will be plenty, and this leads to what's called immune tolerance. And this immune tolerance carry a great role in malignancy transformation in these diseases. And of course, the fear of developing what's called microchimerism. What's microchimerism? Microchimerism, I will give hint about this complication that may happen from allogenic blood transfusion, but let us state this word: the more the number of the transfusion received, the more the hazards. هذا الميكانيزم بيزيد مع increase the number of the transfusion received. Let us take a glimpse. What's microchimerism? Microchimerism, it is a survivor of the donor white disease inside the recipient body. And when this donor cell survive inside the recipient body, sometime this donor cell will attack the recipient cell, and this leads to lysis of the recipient cell, and this complication known as transfusion-associated graft versus host disease. So transfusion-associated graft versus host disease may happen from frequent allogenic blood transfusion. The other mechanism of TRIM is wrong stimulation of the B cell of the recipient. And this wrong stimulation of the B cell leads to production of antibodies. And these antibodies may be HLA, anti-HLA antibodies, may be anti-C, anti-E, anti-Cal, anti-B. A lot of antibodies will be developed in the body of this recipient. And the more the transfusion, the more antibody will be generated. And these antibodies definitely by further exposure will lead to destruction of the transfused blood, and this complication called alloimmunization, and at some time it may be autoimmunization. And definitely this will lead to refractoriness and rejection if this recipient will go for any transplantation in the future. And the more we take transfusion, the more this hazard will be aggravated more and more. I will stop on that. The last mechanism, I give hint about the storage material. When the blood bag stored for a long time, the white disease included inside the blood bag will release this bioactive lipid. And this bioactive lipid has great effect on the immune system of the recipient. It inhibits the neutrophil, it inhibits the natural killer cell, a lot of changes. And the end result is more and more immunosuppression. So it's quite clear. Prolonged storage of the blood bag will lead to aggravation of this adverse effect. So there is a large number of mechanisms that lead to immune aberration in the recipient of allogenic blood. And all these mechanisms will lead to these changes, pathophysiologic changes, microchimerism, immunosuppression, alloimmunization, cytokine release, immune modulation, autoimmunity. Wow, a lot of pathophysiologic mechanism. Definitely these pathophysiologic mechanisms will lead to a great clinical effect. Let us skim what is the clinical effect that will happen in the body receiving such frequent allogenic blood. Unfortunately, our disease today, taking frequent blood, long life and starting very early in life. Secondly, our disease today may be asking for bone marrow transplantation. So even blood transfusion will affect their chance of getting safe transplantation process. So in thalassemia patient, we are chronically transfused. But what is the clinical impact? Definitely it will save life, definitely, but it will put great hazards. Let us review this hazards. The blood receiver, chronically blood receiver are more prone for infection, not blood-borne infection. It's infection in general because they are immunosuppressed. Their immunogenic response to vaccine will be blunted. Please take care of the vaccination schedule of your patient because their response to vaccine will be blunted. Alloimmunization and refractoriness, autoimmune hemolytic anemia and autoimmunity, activation of the CMV, graft rejection, transfusion-associated graft versus host disease, and increased cancer occurrence. Look for the hazards. It's really bad hazards. And these are some of the publication. I will skim it. The autoimmunity and alloimmunization. The most important part of that, how the patient develops such complication will go in a vicious circuit. Because development of such complication will make this patient needing more and more blood. And the more we give blood, the more we will affect the autoimmunity and alloimmunization. And we will enter into a vicious circuit. A vicious circuit. The instance of this vicious circuit, it's not low. We assumed in the past it's a low instance problem, but not low. Look for the instance, alloimmunization in 30% of these patients, autoimmunity in around 7% of these patients. Besides, the years of transfusion and the number of the transfusion received, it is a significant independent predictor of developing such complication. There is increased morbidity and mortality once this complication occurred, and the quality of life will be affected. So such problem is a real disaster. طيب, how could we manage this in the transplantation era? We assumed in the past in a transplantation the only fear is compatibility of the HLA. However, to get a successful transplantation, we should keep the balance between these two arms. And both arms happened by frequent blood transfusion. If the anti-HLA take the upper hand, the rejection will happen. If the microchimerism and immunosuppression take the upper hand, transfusion-associated graft versus host disease will take place. So the complication we are handling today will affect the transplantation in these patients in a dual aspect. So what we need is to keep the balance between these two problems. Let us go, how could we improve this? Definitely, there is no prevention till the moment. There is no prevention. But the things we can do is just to manage this problem, Let us learn how to manage this problem. This problem can be managed by reviewing the guidelines. Why we should review the guidelines? Because, and there are plenty of guidelines, and this guideline is stated yesterday by the TEF team. It's very good, and I found it free on the online. I invite you to review this Thalassemia Review 2022. It's full of very good data. Take the transfusion decision when it's needed to avoid going in this vicious circuit. The second thing, definitely knowing the guideline will help us to manage these fears and to get the benefit to save life. The second thing we should do is to improve the transfusion practice. And I'm happy today, I am among the clinical pathology team and the blood transfusion team, because managing such problem need the collaboration between the blood bankers and the blood specialists. How to manage the blood transfusion? By three things needed: by proper donor selection, by blood processing and good blood processing, by making randomized control trial to know what is the best blood quality needed to prevent such complication. Let us take a glimpse how to better donor selection. How to select your donor properly. The answer is very easy. The donor, the best donor, it is the most compatible donor with the recipient antigen. The answer is very easy. So the best donor, it is the donor that increase compatibility with the recipient. You be careful donor selection will minimize the hazard. How could we increase the compatibility between the antigen of the donor and the recipient? One of the proposed idea is to minimize the number of donors. And I think we worked hard in our Abu Rish Hospital clinic to select 4 donors for each patient. 4 donors for each patient. Sometimes we succeed, others we can't, unfortunately. But if we raise the awareness among the population is to put 4 names, 4 adults for each patient need chronic blood transfusion, it will help a lot. The second thing is by leukodepletion and by compatibility testing between the antigen of the donor and the recipient. Some of these compatibility testing may cover the ABO and RH, and this is commonly done in our in our blood bank, and definitely extension of these compatibility to include other antigens like C, E, Cal, and even extended phenotypic between the donor and the recipient. HLA matched cells, getting HLA matched cell, molecular even matched red blood cell, all these are maneuvers to increase the compatibility between donors and recipient. It's easily stated. However, money is behind a lot of these activities. We should make cost benefit and select the best out of what's stated in the literature, because definitely cost is an important thing. The second thing, to select the best blood donor, we should raise 2 questions. Transfusion from relatives. Should we go for transfusion from relatives or no? The answer, please avoid. Why please avoid? Because transfusion from relatives may increase the chance of getting what's called transfusion-associated graft versus host disease, because of the similarity between some of the antigenic material between the donor and his relative. The recipient will give a chance, bigger chance for survival of the donor cell in the recipient body, and this may increase the chance of transfusion-associated graft versus host disease. So please avoid transfusion from relative, if possible. But how transfusion from a graft donor? Should we go for that? The answer, please no, don't go for that. This is not the best donor for such patient. Why? Because this will increase the incidence of the graft rejection because of the development of the anti-HLA antibody. So selection of the donor is the first point. But what about the blood processing? Yani, what does it mean? What we need from the blood processing? We need to remove all this antigenic material from this allogenic bag. This is our dream. This is our dream. How could we remove all these bad stimulatory antigens from the blood bag? By doing a lot of things. Let us review some of them. white blood cell reduction, depletion, either re-storage, either post-storage, either bedside, but for general white disease reduction. By radiation of the blood, by fresh blood as much as we can, by washing of the blood to wash all the bioactive material inside the bag, by HLA matched product. So there are a lot of processing available. Again, the Faisal is cost benefit. Definitely, all these maneuvers carry a lot of money. I reach my conclusion. Transfusion is still risky. Yes, of course, it's still risky because of this complication, immune inflammatory abrasion from the allogenic blood transfusion. Transfusion of all these foreign antigens from the donor to the recipient will initiate all these pathophysiologic mechanisms that lead to many hazards, many hazards. The way is to manage these hazards by revise the guidelines and take the decision seriously, improve the transfusion practice by good donor selection, by better blood processing, by making randomized control trial to understand more and more about what's best quality blood. These are the best quality blood that we know till the moment. We know till the moment. We don't know tomorrow what's the knowledge will be offered to us. But please, randomized control trial will help in that. I reach the end by inviting you to the conference, childhood conference that will be in 17th and the 18th of November in this hotel. Please book your calendar, waiting for you all, and thank you so much.